So without wasting time, I would like to invite our next speaker. He's our guest speaker from Belgium, Dr. Michael Hermans. Professor Hermans obtained his medical degree in 1984 from Leuven University Medical School in Brussels. He had interest on beta cell biophysics and stimulus secretion coupling in the early research. His interest was on these areas. He is the specialist in internal medicine, endocrinology, and diabetes. He got the Suzanne et Jean Pirard Prize from Association Belgique de Diabetes. He is the visiting fellow at Diabetes Research Laboratories, Oxford University. He is a senior consultant at St. Luke Academic Hospital, Brussels. Professor Hermans was awarded the following diplomas from the Open University in Milton Keynes, UK, Natural Sciences, Science, Human Geography and Environment, and a postgraduate certificate in Social Science. His current research areas are type 2 diabetes, metabolic syndrome, cardiometabolic risk, atherogenic dyslipidemia, and so on. So he will be speaking to us in this session of evolving concepts in diabetes on non-alcoholic liver steatosis linked to reduced frequency of ocular complications in type 2 diabetes. Over to you, sir.
Thank you, Arun. Welcome, Dr. Michael. And it's really great pleasure that, we are meeting digitally after a long time and hope to see you soon, maybe next year, once everything is fine. And Saurabh, I'm just requesting you, I called you also. After this session, you please stay in this hall only.
Okay, sir.
Because there's a doctor had moved other side. Okay. Over to Dr. Michael. Sorry, Michael Hermans.
Thank you very much. I hope you can all hear me and see my slides.
This is not visible. You please share the slides.
So what? Oh yeah, sorry. I need to reactivate the share slide. This should be better.
Yes, sir, we can visualize it.
Is this fine?
Yes, sir.
Okay, Thank you very much. Thank you for the introduction, and thank you to Dr. Bansi Sabu for the nice invitation. I hope next time it will be live and physical. So my topic is a bit different from my previous one. Everything is in the title. What it refers to is the odd observation that in our cohort of patients with type 2 diabetes and fatty liver, we found unexpected decreased frequency of ocular complications that we were not looking for, to tell the truth. So the context of that study was that I wanted to revisit the cardiophenotype of type 2 diabetic patients with and without fatty liver, using a bi-ethnic cohort of Caucasian patients and patients from Africa that are currently living in Belgium, and to compare them because, as many of you must know, African patients have a very different prevalence of fatty liver, which is markedly reduced, and also they suffer very rarely from atherogenic dyslipidemia. So that was the background of that study. So what we did was to revisit the relationship between fatty liver as a cardiometabolic risk factor, which, according to the bulk of the literature, is associated with increased frequency of macrovascular disease. Now, about 15 years ago, I did a small study that was only published as an abstract, in which we couldn't find a difference in the frequency of macrovascular disease based on the presence of fatty liver. Then we let it as it was, and we just increased the cohort size. And what we did was to analyze the patients with ultrasound fatty liver versus those who had no fatty liver, and just to check their cardiometabolic phenotype. This is what I will do with you, and I just reanalyzed a few days ago the latest results, so this is just very, very plain. So we had a cohort of 706 patients with type 2 diabetes, and the majority of them have indeed fatty liver. This is the yellow heading. And there were not there were no difference in gender. Those patients were slightly younger, but not to a marked degree. They had similar exposure to glucose. There was a slight difference in diabetes duration, but in those patients, we have been able to reassess the total exposure to glucose by using the hyperglycemia index. I will tell you later. There was no difference in ethanol intake, and of course, we kicked out of the study the patients with alcoholism. And as you can see, those patients are, majority of them are physically inactive, but even more so when they have fatty liver. Now, the small cohort of African subjects is shown in the lower part of these slides. And in those subjects, the prevalence of fatty liver is about 40% versus a prevalence of more than 70% in Caucasians. So that was expected. And also we had to expel from the study all the Black patients with viral hepatitis, which is very common in Africa. Next, we analyzed, and this was not unexpected, their cardiometabolic phenotype in terms of body composition and body weight. And we found what was expected, a much higher BMI, 4 units of BMI higher in patients with fatty liver. The waist circumference was also higher by more than 10 centimeters. And just to give you an idea, in Europeans, 1 centimeters of waist circumference is the equivalent of about 1 kilogram of fat. Their fat mass was also higher by 10%, as were their neck circumferences. And not surprisingly, those patients suffer more often from sleep apnea. And again, this was expected. Their visceral fat was also significantly higher. So that was expected. As were expected, the changes in glucose homeostasis. So starting from top, they had a higher insulinemia. That was the insulinemia that was measured after a washout of all their glucose-lowering therapies. And that was used to model insulin sensitivity from HOMA. And they had a markedly decreased insulin sensitivity by more than 30%. So that was again expected, as was the almost systematic presence of metabolic syndrome in those patients with fatty liver. They had a 91% prevalence of metabolic syndrome, and they scored higher with the metabolic syndrome, mostly as a result of atherogenic dyslipidemia that I will show you later. Those patients with fatty liver, they have an accelerated loss of beta cell function. We use the hyperbolic product loss rate, and that was also significant. Of importance is the fact that the mean HbA1c level was not different, meaning that they had the same current exposure to glucose, but also they had accumulated exposure to glucose, which was similar. For that, we use the hyperglycemia index, which is the percentage above 6% in HbA1c over the clinical course, multiplied by the non-diabetes duration. So they had ample time to develop microangiopathies. And finally, they were more often using higher dose of insulin, which is not surprising based on their BMI. Again, this was expected from such a cohort with fatty liver. About cardiovascular drugs and blood pressure, there were no difference between groups except for the use of lipid-lowering drugs, which was higher both as regards statins and especially as regards fibrates, which was almost double used in patients with fatty liver. Otherwise, the prevalence of high blood pressure and the blood pressure values was identical, which is good because you have a cohort with the same gender distribution, almost the same duration of diabetes, the same exposure to glucose, same blood pressure, which means that for comparison of macroangiopathies and microangiopathies, things will be easy to unravel. Mentioning lipids and lipoproteins, again, we found what was expected. So no difference in total and LDL cholesterol. And of course, as you expect from patients with fatty liver and high prevalence of atherogenic dyslipidemia, they had decreased level of HDL cholesterol, increased level of triglycerides with a much increased frequency of AD, almost double. And then they had dysfunctional HDLs. I will not go into the details, but they had less and less functional HDLs, and also they had smaller and denser LDL particles, which is shown by the ratio of LDL cholesterol to ApoB100. And finally, they had a decreased level of lipoprotein A, which was already known from our previous works. So based on that, we would expect them to have more macroangiopathies as well as microangiopathies, since heterogeneous lipidemia is linked to both increased risk of small and large vessel disease. The rest of the laboratory values was also expected, higher levels of ferritin, which is often associated with fatty liver, and a lesser level of SHBG, liver insulin sensitivity. And finally, what you all would expect is that they have higher levels of liver enzymes as regards ALT. Now, what about microvascular disease and macrovascular disease? Well, let's start with small vessels first. And this is where we got the unexpected finding of, despite those patients having not different overall macroangiopathy frequencies, there was a significantly lower prevalence of diabetic retinopathy, which was highly significant, 31% in patients without fatty liver and only 20% in patients with fatty liver. But that extended also in other ocular complications, which are not vascular complications, such as cataracts, which was almost decreased in frequency by half, and also by ocular hypertonia, glaucoma, which was also markedly lower. This was not the case for other macroangiopathies, such as peripheral neuropathy and mixed macrovascular complications, such as erectile dysfunctions or the prevalence of macro or microalbuminuria, even though there was a lower level of albuminuria as a continuous variable. So that was highly unexpected. And then we split those microvascular complications according to ethnicity. So we had that large Caucasian subgroup and that smaller Black African patient subgroup. And we found exactly the same difference that were even more dramatic in Black patients, even though it was a small group numerically speaking. Their ophthalmoprotection was even more dramatic, with almost 3 times less overall macroangiopathy, almost 10 times less diabetic retinopathy, a virtual absence of glaucoma, and in African patients at least, with the limitation that it was a very small cohort, we had also less peripheral neuropathy and macroalbuminuria. So a biethnic population showing dramatic reductions in ocular complications according to the presence or absence of ultrasound echography. Now, what about macrovascular disease, which was the whole reason why we did this analysis? Well, contrary to what was expected from the literature, we found absolutely no difference in prevalence of macrovascular disease or specific subtypes. Of course, those patients have a long duration of diabetes, they are old, they have type 2 diabetes, obesity, and blah, blah. So not unexpectedly, they have 1/3 of them had macrovascular disease, but this was not distributed differently according to fatty liver. We did the same with ethnicity and found exactly the same. Now, Black patients have lesser prevalence of macrovascular disease because they are on average younger patients and they have less risk factors versus Europeans. So we published those results a few months ago in a slightly smaller cohort. So for those of you who want to have more details about that, I will refer them to that paper that was published with our African colleagues. And if you ask me for explanations for the difference, well, this is a cross-sectional study. We have not the slightest idea. Similar results were published in patients from Asia. And this is the first study with Caucasian patients and a small group of African patients. So it seems to be observed across ethnicities. And I would be extremely interested to have the same data confirmed or not coming from India, since I expect you have a high prevalence of fatty liver in new type 2 diabetic patients. Thank you very much.
Thank you, Dr. Hermans. That was a wonderful presentation, and we are eager to know much more detail about the factor why there was reduced risk of retinopathy in those patients with
Well, if I had to put forward some hypothesis, first you could imagine that having retinopathy would protect you from fatty liver. This is absurd. There is no known pathophysiology linking the eye towards the liver, so we can probably forget that. This is just ludicrous. On the other hand, there could be some factors which both promote retinopathy, promote fatty liver while protecting the retina. Now, the retina is an extension of the brain with very different cholesterol metabolism, but we found the ophthalmoprotection extending to non-vascular disease, which are not extensions of the brain, such as the cataract, the lens, which is totally unrelated to the retina, and also ocular hypertonia, which is both related to retina and non-retinal complications. Now, one candidate that I put forward in the discussion of that paper could be the LXR activation or inhibition, because that receptor can both promote fatty liver while protecting from retinal complications and vice versa. But we have no data to confirm that, so we will need a mechanistic explanation. But if this is confirmed across ethnicities, that would be a very interesting way to unravel one of the first cardiometabolic risk factors, which is protective for one type of target organ while being detrimental for the other. Even though we did not find an association with macrovascular disease, some of those patients will end up having NASH and liver cirrhosis, but these were expelled, of course, from this analysis. All patients with NASH were not included.
Because in our setup, what we have usually seen is whenever patient is ending up with micro or macrovascular complications, there will be some changes which we also see in retina as well. That's what we observe usually.
Oh, sorry, I missed the first part of your question.
Whenever we see patients ending up with micro or macrovascular complications in long-standing cases of diabetes, we usually see some changes as well as both in liver or the retinal or the microvascular change. That's what's the usual scenario we also observe here. So if this data is going to give us more insight, like what you said, then definitely we have to see.
Yeah, I think we have to both reassure those patients with fatty liver, because it might just be retinoprotective. I am a great fan of using fenofibrate for retinal protection, so I will do that even more so, knowing that those patients may have, by some unknown connections, a liver predisposition to having increased fat in the liver, but also on the other hand, they will have ophthalmoprotection, which is nice to know. But unless we have a mechanistic explanation, this is just like SGLT2 inhibitors. We want to have a nice story to tell, but so far this is just a cross-sectional study, this is observational. But since there were a few papers already from Asia, this seems to be something that went totally unmissed up to now.
Thank you.